contract manager for the IPRO ESRD Quality Improvement Department, and I run the vaccinations, which is not considered healthy living. Let me first thank you all for joining this call. I do want to acknowledge the fact that for some of you, you probably received the message last week pre-holidays, and then for others, you got the message yesterday. My apologies. I did try to get out as much as I could. However, there's one of me and there's like 30,000 of you, so it does take a little while to get the messages across. But I do want to thank you for your time and patience. So I'm not going to keep a long slide deck, but I do want to go over a few things. First thing, I ask that you keep your mics muted. There will be a time for Q&A, but while we're just kind of go over brief information, then everybody can hear. You please use your chat. You are able to definitely advise or ask any questions via chat. And then, of course, raise your hand if you have a question and we can call on you. Next slide. So I wanted to go over basic information. I know there's been quite a few questions that came back to me via email from the letter. So these are the frequent questions that have come up. What is IPRO and who is the network? IPRO is basically the bridge between your clinic and the CMS department, the Centers for Medicare and Medicaid Services. So these are the people, of course, that regulate the dialysis units, making sure that we're going, following regulations and rules and policy, and we're providing the best quality of care. IPRO ESRD is the network that pretty much is the mediation between you and CMS. So we try to provide as much information and resources and tools, interventions for you to help you gauge and improve or do a positive trend in your OKRs, which of course is transplants, hospitalizations, vaccinations, depression, and home incidents and transfers. Another question that continues to come up is, where are you pulling this data from? So let me just first state that performance reports went out through the data department within the week of November 17th. If you have not received it, we have been recommending or asking that you kind of go into the IPRO Learn website and update your contact personnel information. If you have received it, you have and received a follow-up letter, which is that came from me. It's basically giving you guidelines or information in relation to your performance reports. Now, let me also say that information is coming in two different directions. We pull information from EQRS. For some of you, you may know it as Crown Web. And then, of course, NHSN, which is the batching systems. You have your own internal EMR systems that should automatically batch over to these two locations. Now, for EQRS, what you are entering over there is patient influenza and pneumonia. It's reported in EQRS, and then patient and staff COVID, as well as staff flu is entered in NHSN. The other question that I've received is, why is the data incorrect? It doesn't match what's reflected in my facility. Let me state that batching is done once a month. We advise all clinics to update their information into the EMR so it can batch over by the end of the month. It is done one time at the close of the month. And of course, in our department, our data department pulls the information about the first week of the following month. So those letters and performance reports that you have received, it is effective and up to date as of October 30th, the end of the month. So any vaccines that you have provided in the month of November will be reflected in the December report, which is why I have recommended to everybody to please, please, please double check your data. Make sure all your information is in the system. Another question, what if patients get vaccines outside my clinic, the nursing homes, primary care physician, nearby clinics, CVS's, Walgreens, all those others? You are still responsible to have it updated in your system. We ask that you ask the patients to bring documentation of their vaccine so that you can input it in your EMR. And the reason why I say that is because if you do not update it on your system, it's still going to show up on your side as patient not receiving, eligible for vaccine but have not received it. So you want to make sure that you clean up your data as much as you can, okay? Do all you can to get that documentation from the patients. Reach out to their emergency contacts, maybe their caregivers, family, friends, maybe give them a note to take back. Some may forget. We understand that we're dealing with quite a few patients that are senior citizens, so do all you can. Maybe call them once they got home just to remind them. Another question is, what is considered up to date for COVID? Guys, I want to make this very clear. I understand that quite a few patients have received the bivalent. That is no longer considered up to date. The monovalent vaccine based on the Omicron XBB 1.5 sublineagal SARS-CoV-2. I say all that to say, as of September the 15th, that is considered the only up-to-date status. Any patients that have received any vaccines prior to that is considered null and void. So unfortunately, if you are still entering information, my recommendation to you is to stop, halt all extra work. I don't want you to do any double work that is unnecessary, because at the end of the day, it's only going to receive another report stating patient needs up-to-date vaccines. Let me say that again. Up to date is the monovalent, not the bivalent that was given pre-September 15th. So if any patients received the bivalent, thank you, kudos to them. However, based on CMS guidelines and CDC guidelines, it is not considered up to date. And lastly, what are CMS guidelines? Next slide. Quality improvement activity goals, COVID-19 is 80% for patients, 95% for staff fully vaccinated. I stress that severely, guys. In the month, currently we're in 2023. However, medical directors are going to be looking for their QIP scores in the near future. And so with that being said, you want to make sure that your staff is entering the information as to where they stand in their COVID guidelines. Why? Because in 2023, if they received the vaccine, medical directors of facilities receive those scores for your QIP guideline scores in 2026, whereas you will receive reimbursement. Everybody should know that QIP scores are like 2 years lag. So what you do in 2023 will not be reflected until 2026. Anything that you did in 2020 and 2021 will be reflected in 2023. So just be mindful of all the information that you're entering as far as your data. Influenza for patients and staff is considered 90%. And pneumonia, of course, is to achieve a 7% increase from the baseline. So when we say that you're under, it's not based on, we want to get everybody fully vaccinated, obviously, for the pneumococcal vaccine. Obviously, we want 100%, but it's 7% of your original baseline of your patient census, okay? And then, of course, the question of the day was related to the weight reduction. Weight reduction is still currently under review under CMS guidelines. That will eventually either come off, because there's still been quite a bit of conflict or questions as to what is considered a safe alternative for BMI metrics for dialysis patients. But as of right now, it's still in the works to be used as a CMS goal for your OKR for vaccinations. Next slide. That is basically all I have. I did not want to keep it long and unnecessary information. We all work in healthcare. We understand the importance and the guidelines of vaccinations and making sure that patients get vaccinated. I understand also that we're having barriers within clinics. We have hesitancy with patients where vaccine fatigue. It's so many out there. It's a lot going on. However, at the end of the day, our job is to continue to keep encouraging, to be optimistic, to continue to keep going after those that could, decide and decline. Now, I'm going to open the floor to any questions that you may have. Please raise your hand, come off a mic, come off of mute, or go into the chat.
Can you go over again, you said the COVID given pre-September 15th is acceptable and anything given after is not acceptable?
Anything September 15th is no longer acceptable.
Okay.
Up-to-date status is any vaccine after September 15th, the monovalent that is currently being offered at this moment. Okay. I believe it's under Pfizer, and BioNTech is also offering it. Be on the lookout, though. There is a possibility that in the near future, currently the monovalent that is being offered is for the strain of the Omicron variant that we had dealt with last year.
Okay.
However, I believe if I heard recently, there is a new variant that is currently out, something with the H. Please don't hold me to my words, but just be on the lookout because it's a possibility that the strain may change and then the vaccine may change. However, as of right now, September 15th, monovalent is the up-to-date status. So anything prior to that is null and void. You are basically starting the clock over.
Gotcha. Thank you.
You're welcome. Any other questions?
I have a question.
Yes.
The reports that our facilities are getting through IPRO of their vaccinations being lower, do they need to manually enter these, or do we just wait until the next batch because they were in November?
Recommendation, and I will also let Svetlana join in. She is the assistant director of our data department. However, my recommendation is to double check your EMR, your internal EMR, to make sure that your information of vaccines administered has already been updated. You've given everything, you've entered it. At the end of the month, the batching will take effect on our end. And so because we only pull once a month, everything that you've entered prior to the end of the month will show up on our end. You do not have to manually enter anything in EQRS extra that is unnecessary. Svetlana, is there any other information you would like to offer to that?
Yes, thank you, Tiffany. Hi, everyone. On the top of every report card, you will see a date of when that report card is current as of. So everything should say October 31st. So if your batch uploaded data into EQRS or NHSN November 7th, that's not going to be on the report. It will be batched, like Tiffany said, throughout November, and then it will appear in your November 30th report. But each patient will get the true date of when that vaccination was reported. So when you get your next report and you believe, wait, we should have 100% vaccination by now, we blasted it through November, everybody got one, then you can look at the UPIs on the report to see who's left, and then you can troubleshoot those UPIs either with a batch to find out why their data didn't come through, or you would log into EQRS to see what looks different, why didn't it go in correctly, and you could reach out to us and we could help investigate and help you problem solve that as well.
Okay, thank you.
Any other question?
Yes, I have a question. Can you give me some reasons as to why it wouldn't go in correctly? Because I have a few that are people that are on my influenza report, and I'm looking at it and it says as of 10/31. But I have a few people that got their flu shots in early October, but they didn't cross over. So can you give me a few reasons that some things that maybe I can look for to see why they did not cross over?
Sure. You could even, if you want to give me the UPI, I can take a look right now and maybe it'll help people visualize what it looks like, and I'll try to explain without revealing any PHI what the issue might be. Can you tell me which network you are with or which state?
Network 6, North Carolina.
6. Great. And then can you please tell me the UPI of the patient?
Okay, so this particular one is 310-3562-793.
793.
NHS staff flu vaccine supposed to enter and how often?
So let me log in to EQRS. And of course I have it sitting and waiting. And
for the pneumonia vaccine.
Tiffany, we can hear you.
Oh, I'm sorry. I'm reading the question.
1 second, this doesn't want to cooperate, of course. But there could be a couple of reasons why the data doesn't batch. It could be even a slight typo in the patient's name in your batch system versus what's in EQRS. There could also be sometimes too many batching, and they kind of contradict one another, and then maybe the data is slightly off somewhere. So I'm trying again to go in, and I'm gonna look up this patient and tell you what I see for this patient in the flu vaccination. Is that right?
Yes, ma'am.
Okay, so for flu, I do see dose was received, flu zone received on October 2nd, but see this data was recorded in EQRS on November 8th, but our data was through October 30th. So the reporting that happened on November 8th didn't make it into the October reporting, but it should on the next time we get this report from CMS. Does that make sense? It's all about the timing of when the batch happens versus when we get these reports from CMS.
Okay, all right. All righty. I'll look for it. Thank you so much.
Sure. That's a perfect example. We know the reports right now are very long, and we know that you all started the vaccination campaign recently. So hopefully the report cards will show a much higher vaccination rate. But any UPI that you see, please go into EQRS and just look around to see what the data looks like. And you will see that column called date recorded, and you will see when that vaccination was actually posted in EQRS. And I'm going to share some instructions right now with screenshots of what it looks like in EQRS for you.
Svetlana, there's a question of, is there anything wrong with manually entering the vaccination information if the EMR does not batch?
The only thing wrong with that is that the batch could suddenly start working and erase all the work that you've done manually. So I would work with your batch submitter to identify the problem before you start manually taking your time doing this.
Are there
Anything
any other
else?
questions?
I have a question.
A copy of this in the email or the PowerPoints that are
Hi,
being.
Lori.
Hi, someone else was asking a question.
Oh,
Are we
Got an
getting a
email.
copy of this PowerPoints?
I'm sorry, I can't hear you in the background.
She's wanting to know if we'll get a copy of the questions and this PowerPoint in the email.
The webinar is being recorded, so we can send that out. In regards to the questions, I can, it's already in slide deck, but there are additional questions. I will just do a small type up and send that as well.
So my question is, so our batch went over on the 7th. So does that still count everything of October? We've checked our EMR, we've checked EQRS. Everything is correct within the report we're getting from NHSN is not correct compared to that. So our vaccinations were all given on like October 2nd, but our batch wouldn't have went over till the 7th of November. So it doesn't count, is that correct, until our new batch goes over December 7th?
No, the reports we received were run on October 31st. So if the batch didn't happen until a week later, that wouldn't have been captured in the report. It will be captured next time the report is run on November 30th, which will capture all the data that was batched on November 7th.
Okay.
So everybody will have the correct date of when the thing happened. It's just a matter of when did the batch happen versus when was this report created.
Okay, thank you. I understand.
Sure. It's also important in EQRS, when you go into each patient's vaccination section, there's a little section underneath each one that's called doses not received. And sometimes that can trip you up because it could have information that says dose not received on October 5th, which will interfere with dose yes received on October 4th. So when you see a UPI on the report, go in and expand their vaccination section and just see if there's anything weird going on in there. Sometimes it just needs a tiny bit of cleanup, and then the data will look correct and appear correct on the next report. So please look at those screenshots that I just shared in the chat, and hopefully that will help you make any cleanup that you need. And you can also always submit a ticket with the UPI, tell us which report, and we will investigate and let you know why they're coming up on the report. Kim, to contact your batching issue, it depends who your organization is. If you're DaVita or FMC or US Renal Care, you should have contact info, probably even right off your desktop, to contact corporate support with these questions. And Tabitha, patient flu vaccination goes into EQRS, not NHSN.
What other questions do you have?
I'm happy to look up another UPI if anybody wants. Just make sure you don't reveal the patient's name or anything in this discussion.
We also make notice that I understand that we're in a short window of time. I do understand that, you know, when we start campaigning for vaccines, it's usually in August, September, and then of course, you know, you're starting your influenza season in October, and then some vaccines don't make it to facilities until November, which is why this is very critical for cleanup. Because as of January 1, you pretty much know flu season is almost over. And then, of course, we're just kind of cleaning up our systems and shipping back whatever extra inventory we no longer are using if your facility does that. This is why we're trying to make sure that we are just kind of giving you the tools and resources and information you need to kind of clean up the your systems, and finding out where those problems are coming from before December. Holidays are coming up, and of course, you're going to be there might be some staffing issues, and the person that does EQRS or NHSN might not be in the building. So it's very serious that are critical that we kind of clean this up before mid-December. There was a question about the pneumococcal vaccinations. Svetlana was nice and kind enough to put in the CDC guidelines of where we sit with pneumococcal. Again, the up-to-date status is what they are recommending for the PPSV 23 if your facility is offering it. And then, of course, your PCV 13. If you are still offering the PCV 20 in your facility because you're trying to, use up what you have, or that's what your facility offers, that is perfectly fine. Just monitor that algorithm. It will tell you exactly what next steps you should take on regards to what dose and the brand that you're using. Also, the other question that I did receive from a clinic was, which guidelines are you using? You want to go by the immunocompromised conditions when you are offering those pneumococcal vaccine schedules. There was a question of whether or not it's considered the immunocompromised or the chronic health conditions. We are going based on immunocompromised guidelines. Okay. Are there any other questions?
That's a good point, Tiffany. The ESRD patients are considered the worst case scenario according to all vaccination needs, meaning they need whatever the most critical version of it is, according to the timeliness of when the next one is due.
This was an opportunity for you to bring any questions that you might have vaccine related.
Yeah,
Yeah.
ma'am.
I'm
This
here.
is Maria. The pneumonia's been confusing for me.
That's
We've been given the 23. all the way along. And then I was told that it's recommended that we do the Prevnar 20. So, and I have the algorithm right here. I don't know, I'm kind of struggling with this.
Specifically struggling with the algorithm, or just the fact of the brand that is being offered now?
The recommendation, because like I said, I have always given the PPSD 23,
Mhm.
and now I'm being told that I should be given the 20. I don't know, and I just heard you say that it's recommended the 23 now. So I'm confused on this because all of our patients, except for maybe a handful, are up to date on the vaccinations, and a majority are the 23s. But it shows as though we barely have any patients that are up to date.
We're in the same boat here. That was just about to ask the same question.
Okay, so the information is being pulled from CDC guidelines. I just dropped in the website. It says here for adult recommendations, CDC recommends PCV 15 or 20 for adults who never received a PCV and are over the age of 65. If PCV is used, PCV 15 is used, it should be followed by a dose of PSV 23. However, adults 65 or older have the option to get the PCV 20 if they have already received the 13 or the 23 and the 23. So again, it's just one of those algorithms that you have to follow through the CDC. We do not provide, as far as IPRO, we don't give you guidance on which ones to give, but CDC will give you the algorithm based on what you've already given the patient or what the patient has already been given prior to coming to your facility. And I have heard that some facilities have one or the other because they're trying to get rid of it. That is perfectly fine. As long as you are following the algorithm of what CDC guidelines state, you should be fine. And making sure that you're updating the information into the EQRS system.
Okay.
Unfortunately, just like how the COVID guidelines just changed, CDC can decide when it now prefers one vaccine over another because it's more appropriate to the strains going around, and with time tells effectiveness of vaccines. So it's challenging when you go from using one vaccine consistently, PPSV 23, to now being told you should no longer use that one.
Yeah, I have to agree with you there.
Yeah,
Oh,
it seems like that's what
goodness.
they feel would be the best coverage going forward for those that have a 23. It seems like the 23 is still effective if the patient had PCV 13 or none. But if they've already had a 23, then they're due for their next version, which is a 15 or a 20. Yeah.
Okay, so if they've had the 23 and we have, I'm looking here at the spans, with the 23, it's greater than 5, then we would go with the 15 or the 20.
Yes.
Okay. But with the 15 or the 20, it's greater than a year, and then they can go up to the 23.
Correct.
Yes.
Okay, I think I'm getting a little bit of this.
And Svetlana was absolutely correct when she said it's based on their guidelines. Just like the COVID is considered up to date with the monovalent, it can change in 3 to 4 months with something totally different of what is considered up to date. So we just have to consistently be checking our websites, our information, making sure that we are staying on top of the up to date status, and not double working yourself or overworking yourself, entering information that might be, null and void or obsolete.
Okay. All right, thank you.
You're welcome.
I'd like to add something else, and this is challenging, and Tiffany and I have spent hours trying to make sense of this, running through different scenarios. We found one patient, and we're we're considering bringing this to CMS attention for review, where this 5-year gap fell short by 2 weeks. And the patient is shown as requiring one, even though they got the vaccine at 4 years, 11 and a half months. So we're going to talk to CMS to see whether or not this patient needs another vaccine or not, or if they can be counted as done. So there's definitely situations like that that happen as well. It is confusing, but please come talk to us about it. We will investigate and escalate whenever we can.
Any other questions?
We're here for you guys. We're here to
Yes.
answer any questions. If you want any UPIs looked up, if you want to talk about any of the report cards, please let us know. We've got half an hour. We're here for you.
Are you able to understand the report cards? That's a good question.
And if not,
Nope.
please give us feedback, because we're not making them for fun. We're making them to help you guys, and we want them to be useful and clear and help you and your team make decisions. So please, whatever, oops, we see an email on the screen right now. We'd love to know your feedback about anything that we send, what can be improved, what can be more clear. We see an email on the screen right now, whoever is screen sharing.
Yeah, I know. I'm trying to get it to go away.
Thanks, Steph. If you can give us a thumbs up on the performance reports to let us know if they're okay, that will help tremendously.
Awesome. Thank you, Mom.
Thank you.
And if you're not getting the report cards, please make sure that we have your correct contact information. We often do not. We get so many bounces whenever we send stuff out, but please, please, please update your contacts here. I'm pasting the link right now, and please check for typos. A simple comma or, some letters swapped will really throw the whole thing off, and you'll never get the emails from us.
And while we're talking about emails, thank you for updating that information. If you are no longer the FA or the EQR's representative or the person that doesn't handle a specific facility, please, please, please go in. I've received quite a few emails advising that you don't handle this clinic, or you're no longer the FA, or you are not even within the dialysis world. It's very important that that information stays up to date and current, because number one, you want to receive the correspondence from the network so that you're kind of staying abreast or on top of information. And the other reason is for us so that it doesn't give us so many kickbacks. I know, as I said in the beginning, I've sent out about 25,000 emails, and the reason why is because again, we don't know if teammates are still there, if they're still covering that clinic. So who was included on those emails? FAs, EQRS, NHSN representatives that entered information, head nurses, and then of course your clinical manager. And again, it's because of that reason. It's not to antagonize anybody or to call out anybody, but it's because we don't know who's still available. So we have to reach as many as we can and receive the response back. So if you know John Henry is no longer your FA, go in the system and say now it's Beth Wingles. I don't know, whatever her last name may be, so that we can just have an idea. And Svetlana is absolutely correct. Be conscious of the typing. A simple note when you type out com and forget the M will bounce it back. So please, when you have time, just kind of go in and make sure all your contact information is up to date on your end.
Yes, unfortunately, we don't have the capacity to make these updates for the facilities. There's 2,000 facilities with about 30,000 contacts among them. So we cannot physically maintain this information ourselves. We ask that everybody takes care of their own facility, please.
Hey, good morning. This is Julie from Nashua. I do have a question on the influenza vaccination report.
Hi, yes.
I understand that you pulled the influenza and the COVID vaccination data from NHSN. And I had asked the question because you had said if there's a question about it, your batch submitter. So I'm trying to look into that. But my question is, when it lists the current eligible staff,
Mhm.
that number is quite high. So who all
Yeah.
is that incorporating? Because I definitely do not have that many staff.
Yeah, good question, Julie. And I'm gonna assume that you're part of a hospital.
No, I'm a dialysis facility.
Oh, boy. Okay. Um, May I suggest that you then submit a ticket to us and provide, and if you haven't already yet, I know I'm working on a couple of these cases as well. Usually a hospital will submit NHSN on the hospital level, and that's when you'll see like 3,000 staff, 4,000 staff. But if you're just an independent dialysis facility, it could be just a typo. NHSN asks for aggregate data, meaning how many total staff are in your facility, how many total staff got vaccinated. So that could just be a typo, but if it's part of a big hospital chain, it is difficult to break apart the personnel without doing some digging and collaborating with the NHSN help desk. So Julie,
there's-
if you could. Mhm.
So there's no way for me to go on. So like it gives my current eligible staff as 32. There's no place for me to go on and validate what 32 people they're looking at, teammates, staff.
There isn't. That was entered manually by somebody. So you can go in there and you could update that count to be whatever you believe is accurate.
On the NHSN website.
Yeah, yeah.
Okay.
And then I'm on the CDC website right now trying to find, oh, I think I shared those, instructions for entering it. And unfortunately, the best I can do is links to NHSN instructions for entering data because we don't see the same thing facilities see. We can't do the same troubleshooting than we can with EQRS. So please, look at these links that I just shared, and those should have screenshots of where to go to enter specific vaccinations for staff, for COVID, for flu. So please dig around in those instructions and see what you see. Also, when you get the report cards, you might be reporting the data under one NHSN ID that we don't even know about. So I know I've done some outreach this month to try to clean those up, but please let us know if there's a missing data somewhere that shouldn't be missing, or there's a gap, or the timing is off, because there's a lot of dots to connect, unfortunately. We even had one case where a network 2 facility ended up in a network 6 NHSN group, and they were double reporting in 2 different states. So situations happen. Please reach out to us and we will work with you to get them resolved for the next time.
This is the report. We person by person. Yeah. And these people are all missing. And I wrote to Seth and Angela asking for updates.
Any other?
Oops, Tiffany, I think you got muted.
We're here for you. We have about 20 more minutes. Any questions that you might have about vaccinations at all, data, anything?
And please remember that IPRO Learn activities are due in 2 days. The new month starts on the 1st, so please make sure to go in there and make sure everything is marked as complete.
Since we're talking about IPRO Learn, if any of you are part of a coalition, please be mindful of your project outline dates. This may not be, you may not be part of it. I may not have nobody in the coalition. But if you are part of any coalition, please be mindful of the project outline dates. Currently, we are in our RCA period, so you might want to go in and get that done before the holidays, and address any questions that are there, and just kind of making sure that we are doing all our IPRO Learn activities. Again, this is to help, make improvements in your area of OKRs that you're having, difficulties in. I'm reviewing some questions that might have came up recently. But please drop your question in the chat. Please raise your hand, come off a mic. Let us know what your thoughts are.
And I'm going to use this 30 seconds to again plug the importance of preventing security violations. I know I scared a lot of people last week when I sent out a blast reminder that the network reported almost 30 security violations to CMS in like less than 20 days. This was general, IPRO wide. So if if somebody at your facility did it, you would have heard it directly. But please, please, please be sure that everybody's aware of how to properly communicate PHI to the network. No names, dates of birth, social securities, MBIs, no initials in emails or tickets. This is CMS policy. You have to follow that policy as well as your corporate policy. They don't always work the same. So please be always mindful and aware of how you communicate patient information with the network. It's always safer not to include them in emails. That's what the UPI is for.
What is the website that clinics go to submit tickets to the help desk, Svetlana?
To our help desk, the ticket link is this one right here. Yeah. help.esrd.ipro.org. And Sandra, once IPRO Learn month has closed, it's closed because it goes back a very long time. It would be unwielding if we kept all the prior months open.
I will say this though, I was able to, if you are part of a coalition, and say for instance, I had a facility call and say, I do not recall what we submitted for our plan, and they were already in their study portion. I was able to pull some of that information of what they entered as their, RCA or their plan. So if you are part of that, there is ability for me to see and pull it. But yes, Svetlana is absolutely right. If once the month closes, we are unable to see exactly which clinics participated. However, if you want to do a little deep diving, I might be able to pull some of that. If a patient or staff member has not had the Omicron, is not counted as up to date. Oh, if they have not had the Omicron, that is correct. They have to have the new monovalent that just came out. Only patient staff that has received will be, that is correct. That is absolutely correct. So when you receive your performance report and it says they are eligible for a vaccine, but they received the bivalent, which is the old vaccine, it's because they are no longer considered up to date. So your scorecard is always going to show them eligible for a vaccine until they receive the new up-to-date vaccine. Any other questions? Is there going to be any changes for the 2744 this year? Svetlana, perfect question. 2744.
There are no changes. We plan on starting them in January, early February at the latest. Please make sure that you're running the patient roster verification to prepare so that you could close out the year with the correct patient census. And I'm gonna even do a quick plug for the instructions on how to run the patient roster verification. This is patient roster verification. This is a really, really important best practice for facilities to adopt and conduct every month. This used to be called the PART a long, long time ago, but it's no longer required. But it has been identified as a best practice. If a facility does this once a month, at least, they'll be in pretty good shape to prepare for the 2744 because you can address patients on a monthly basis rather than go back and figure out what happened a year ago. I
I
hope
have
that
a
answered your
question.
question. Yes.
This is actually for the facilities. Has anybody initiated or utilized the Healthy Living Bingo game at their facility as of yet? It was released back in October for the network service area, and I received quite a few responses stating that it was going to be a holiday themed game. So, is anybody aware of the Healthy Living? Thumbs up, thumbs down? No response? Okay, so someone's doing it in December. Yep, thumbs up. Thank you, Christy. Thank you, Chris. Thank you, Bonnie, Barbara, Jamie. Okay. If that is something that you would like to include in your holiday extravaganza at your facility, please let me know. You can send me an email, drop me a note, and I will send you all the intricate information. Thanks, Ruth. With the game, it is meant for about 10 people at a time. However, it will definitely change the environment, change the morale, give them something different to do while they're sitting in their chairs. I know I've been getting quite a few responses of they don't, you don't have enough staff, not enough time. However, we are in a season of holidays, and you do know that this is the period where quite a few people, including yourselves, may be going through some periods of holiday depression or just, downwardness. We want to make sure that we just kind of keep the morale high, especially during the fact that they are in dialysis 4 hours out of a day. So let me know if you would like to have it, and I'll gladly send it over. Bendrick, if you just send me an email, I will drop you everything in the email, and I will, you can choose to do it anytime during the month of December. Thank you, Leslie. Any other questions? We would love to have it. Absolutely. Send me an email. Just send me a chat, anything, and I will forward it to you immediately. Charlotte and Lori, I'm sending it right now. Lori, just drop me your email address in the chat and I'll send it. Lee, thank you. Are there any other questions?
And links to bingo have been included up above as well. So it's the second to last link called Healthy
Thank you.
Living Bingo.
Please feel free to drop any questions that you may have. Death notifications. Do you have any questions about your 2746s?
Which do not need a signature and do need to be submitted within 14 days of the date of death.
Are you having concerns with your directors signing your 2742s? Do you need any assistance with that? Suggestions, ways to improve getting those signatures and updated in 45 days? Seems like we're good there.
I see some questions. Do hospitals report death notifications? No, hospitals do not complete the 2746 forms.
By the way, since you're talking about 2746s, you do have the ability to, if you do not know the diagnosis of why your patient has passed away, there is the ability to put an unknown in and still get it submitted. You don't want to miss that. Is it 14 or 15 days? I apologize.
14.
14-day period. And the unfortunate thing is it will sit there. What usually happens after the 14th day? You don't get credit for it, is that correct?
Your compliance rate decreases.
There you
CMS is monitoring how many forms are submitted on time, and your compliance rate will continue to decrease for any missed deadline.
So it's very important that even if you do not know it, you still want to put an unknown. How many days of hospice do you have to do? One? I'm sorry. Lisa, do you mind coming off of mute and just kind of expressing that question a little bit more? Lisa Weber, you still there? Okay, if they're in hospice and you discharge them, how many? Okay, so Svetlana, if they're in hospice and you discharge them, how many days after do you have to get the 2746 done?
I'm trying to understand this question. If you discharge a patient to hospice or hospital or discontinue and they die within 30 days, then you have to do the 2746 form. If they die after 30 days, then you do not need to do a 2746 form.
Another way to find out about a patient's death, I used to run a facility. I was also the administrative assistant. I find that if you contact the funeral home, so just in case some of you are not aware of this, if you contact the funeral home and tell them where you're calling from, quite a few of them will be kind enough to send you a copy of the death certificate once they receive it, so that you can see the causes. And definitely have it on file. So even if you don't know it within those 14 days, you can always reach out to the funeral home if you are aware of where they're going and work with them, and they will sometimes send it to you.
Thanks, Tiffany. Good to
You're
know.
welcome. Questions, drop them. We have 7 minutes, and I know y'all got to get back to the floor. Any questions that you have? See, how do you manage a patient who is in the hospital for greater than 30 days and gets transferred to another hospital?
You would only discharge them at the first 30 days, and that's it. And just monitor them to see if they're going to return.
Discharged to where?
Hospital.
Mhm.
On the last day that they treated at your facility.
Any other questions? So just a heads up, any information that you have received, by no means, please contact your sister facilities, maybe another AA, another EQR's representative that you did not notice on your screen, and just kind of provide this information to them. They may not be aware of, the guidelines and the dates and all that information. So please forward the information. How can we delete an admission EQRS that was entered incorrectly? Svetlana.
You would have to submit a ticket and we would investigate whether or not that admission can be deleted. Nothing is simple with EQRS, so we'll help you troubleshoot. And please
And
do
another,
submit a ticket. We are not able to handle incoming phone calls. Tickets is the best way to get to us and get a response as quickly as possible. Sorry, Tiffany, go ahead.
no, it's fine. Please let us know if this was helpful. We are looking to do another open office hours probably in December, maybe early January. And then the data department often does one every month. If this information has been helpful and you think this was, you know, a positive engagement, please thumbs up would be very much appreciated. Thank you, Lisa. Thanks, Barbara. Chris, Lisa. Thanks, Brittany. Dawala, Miles, thank you so very much. I see you, Cheryl. Sarah. Thank you so much, guys. We really do appreciate the enthusiasm and then the participation. Thank you, Tia, Antoinette, Bridget, Christy. I feel like I'm on an episode of Romper Room. But if at all you have any additional questions, you know how to reach us. As I mentioned, my name is Tiffany. I am the Vaccination Project Manager. If there is a coalition, thank you, Charlotte. If there's a coalition that you're in, transplant or hospitalizations, we can get you in the direction of the person that handles those departments. Our PFR lead, Aisha Edmondson, and Stephanie Cole, who assists us. She's on our call today. Stephanie, thank you. If you have any questions, we can get you to the right direction. Follow-up from last open office. Has the IPRO site been updated with fee-for-service priority diagnosis codes? Good question. Svetlana, do you know anything about that?
Yes, I just pasted the link. Thank you for the reminder, Jody. I think this is a special request and we made it happen later that day. And I probably forgot to tell you that we did it. But here it is. We posted all the ICD-10 codes that CMS is using right now to determine whether a hospitalization was ESRD related or not. So when you get the hospitalization report cards, these are the patients that are being counted as an ESRD hospitalization. As long as the hospital admission mentions any of these codes, the patient will be counted in the hospitalization QIA.
Okay. Well, thank you guys for everything. You all have a happy holiday. Enjoy your family and friends. And make sure that we pushing those vaccines. And if you haven't, please get yourself vaccinated, not just for you, but for your family, those loved ones that you're getting ready to see and visit. Call if you have any questions. Thanks, Tracy. Thanks, everybody. We'll stay on, I'll stay on for a little longer if there's any additional questions.
Thank you all. Stay safe.